Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Stand Medical Notes. Today we will discuss about the topic of cardiac arrest. Okay, so let's begin with the name of Allah. So, what is cardiac arrest? Conceptual and a comprehensive review. First, we will discuss about the definition, pathophysiology, etiology, and epidemiology of this cardiac arrest. So, cardiac arrest, cessation of cardiac mechanical function marked by absence of pulse, unresponsiveness to stimulation, and apnea or agonal respirations. Without prompt reversal, it leads to death. So, what is cardiac arrest? Basically, it is a cardiac mechanical dysfunction. So, there is absence of palpable pulse. We need to palpate the central pulse. Remember, central pulse, central carotid pulse. Unresponsiveness to stimulation, apnea or agonal respirations. Agonal respirations in the context of cardiac arrest are considered as apnea only. Okay, so if you don't reverse this, it leads to death. So that is cardiac arrest. So next, what is sudden cardiac arrest and sudden cardiac death? It's a fatal symptom complex due to sudden loss of cardiac output and hemodynamic failure. So it is a symptom complex which leads to death. It's a symptom complex which leads to death, and in this there is a sudden loss of cardiac output and hemodynamic failure. So it is defined by ACC, American College of Cardiology, AHA, American Heart Association, and Heart Rhythm Society as sudden cessation of cardiac activity so that the victim becomes unresponsive, no normal breathing, and no signs of circulation, meaning no pulse, no BP you will record. So same things. Okay, so that is sudden cardiac arrest. So that will lead to death. So death due to cardiac arrest is sudden cardiac death. So what are sudden cardiac arrest survivors? So individuals who achieve return of spontaneous circulation, ROSC in short it is called, through successful resuscitation or spontaneous rhythm reversion, either by resuscitation or by spontaneous rhythm reversion with sustained cardiac output. Those individuals are called as sudden cardiac arrest survivors. Okay, these are the important definitions. What's the pathophysiology? How does cardiac arrest occur? So remember, there will be an anatomic substrate in the form of cardiac muscle scar or hypertrophy of the cardiac muscle or fibrosis of the cardiac muscle. This is the baseline thing which will be there, number one. And number two is electrical instability. This is the second baseline thing. Electrical instability can be due to channelopathy or action potential duration changes, QT prolongation syndrome, Rugara syndrome, all these things constitute electrical instability. Okay, and also in an anatomic substrate will create electrical instability in the heart, because these scars or hypertrophy or fibrosis, what they will do, they will act as a resistant tissue, and they will help in creating a re-entry circuit. So this is the cardiac muscle part, damaged cardiac muscle. So this will act as a resistant tissue, and they will help in creating re-entry circuit. So anatomic substrate will also create electrical instability. So when the cardiac heart becomes unstable, some triggers like ischemia or electrolyte abnormality like hyperkalemia, hypocalcemia. Okay, physical or emotional stress due to autonomic, so you will the sympathetic overdrive. So either due to ischemia or electrolyte abnormality or sympathetic overdrive, that electrical instability is converted into ventricular fibrillation or ventricular tachycardia, and that will lead to sudden cardiac arrest. That's the main things, okay, which will be there. So these will be at the baseline: anatomic substrate, which can be a scar or hypertrophy or fibrotic cardiac tissue, and that will lead to electrical instability. Okay, now upon this anatomic substrate, if the triggers act in the form of ischemia, electrolyte disturbances, or sympathetic overdrive, that will create this ventricular arrhythmias. Okay, so autonomic nervous system has an important role. The autonomic overdrive will modulate this electrical instability. So in some patients there will be electrical instability. Why that electrical instability will be? because of some morphological factors, some cardiomyopathy, some hypertrophy, clinical factors, okay, or heart failure. So what happens in heart failure? There will be neurohumoral Rais activation, no? So all these factors, what they'll do, they'll cause left ventricular dysfunction. And on the other hand, coronary artery disease or coronary stenosis, what this will do, this will create a state of chronic ischemia. This state of chronic ischemia again will cause electrical instability. So any trigger in this electrical unstable state will cause arrhythmias, and arrhythmias will lead to cardiac arrest. That is the basic mechanism behind this cardiac arrest. So baseline, at the baseline there will be anatomical substrate and there will be electrical instability. Causes for these two will be left ventricular dysfunction and ischemia. Basically left ventricular dysfunction, ischemia cause this anatomical electrical instability and anatomic substrate, and some trigger factor will generate arrhythmias, malignant ventricular arrhythmias, and that will lead to cardiac arrest. That is the mechanism. Now moving forwards, so you found a patient with cardiac arrest. So how do you deal with? See, remember, cardiac arrest is not death. Actually, cardiac arrest is an event between life and death. So if you act at that event at a proper time, so that patient can survive, okay. And if you don't act, so patient will pass on to death. So cardiac arrest is actually an event between a death and life. So to take the patient back to life, so we need to maintain a chain known as the chain of survival. So survival from cardiac arrest is dependent on a sequence of integrated interventions. So these are 4 links actually. These all must be strong. First is early recognition and call for help. This is to prevent cardiac arrest. So some patient is having some chest pain or something we are saying which is related to heart. So we should recognize it early and we should call emergency helpline, which differs from country to country. Okay, in India, especially in Karnataka state, 108 we will call. Okay, so it depends the emergency helpline number. Okay, so you should call. So till that time, if you feel that patient is unaware and he is not breathing or there are agonal breathings and there is no pulse, then start CPR to buy time. CPR is nothing but cardiopulmonary resuscitation, chest compression and breathing, mouth giving breath to the cardiac arrest victim. Okay, so and if possible, this is difficult in developing countries, but in developed countries it is common that they have this automated electrical defibrillator. So they will so one can attach those automated electric defibrillator and he can try defibrillation with that to restart the heart. And but if he does not have that AED, then the next step will be to call to do the CPR as usual and call the emergency services. When the emergency services will arise, they will give the patient advanced life support, ALS. So till that one should have BLS, basic life support, nothing but call and perform CPR in 30:2 ratio. Okay, so these are the very important four things. Okay, so if now after this CPR and if the patient returns on spontaneous circulation, so we will institute something called as post-resuscitation care to restore the quality of life. So this chain is very much strong in hospital settings, but outside it is, so we can do up to CPR only. Okay, and in some developed countries they will have AED, they can attempt defibrillation also. This post-resuscitation is possible only in hospital only. Okay, so remember these 4 things: early recognition and call for help, early CPR to buy time, early defibrillation. So basically what you are doing in CPR, so you are doing the work of heart and lung, passive work. You are doing that, you are compressing the heart. So nothing, you are compressing the sternum of the victim, so that presses the heart and that will push the blood to the most vital organ, that is nothing but the brain. Okay, coronary circulation, heart, coronary circulation, as well as cerebral circulation. So the blood flow to those organs will be maintained by CPR. That is the main goal, that is the main concept behind CPR. And by giving breathing, you are giving air into the lungs. So you are giving air by mouth to mouth breathing or by some bag and mask ventilation, and after giving that breath, you are compressing the heart so that uh, the oxygenated blood is coming, and you are just pressing by your compressions to the vital to maintain in order to maintain the vital organs perfused. Then the next is defibrillation to restart the heart, and then once if the patient recovers and he has ROSC, then we will plan for post resuscitation care to restore the quality of life. Okay. So moving forwards, okay. Now, what are the etiology? What are the causes of cardiac arrest? And what are the presenting rhythms? These are important to know to perform ALS. Okay. So, what are the important causes and presenting rhythms of cardiac arrest? So, important causes include uh, you can divide the causes into, one is primary causes, primary cardiac causes, and secondary cardiac arrest. Primary is most commonly cardiac condition, most commonly coronary artery disease, and secondary cardiac arrest, non-cardiac causes there. So acute coronary syndrome, ischemic heart disease. So these constitute the vascular cause, and cardiomyopathies. This constitute muscular causes, muscular cause. Then congenital arrhythmogenic diseases like long and short QT syndromes and Brugada syndrome. This constitute arrhythmogenic causes, arrhythmogenic causes. Structural heart disease. So you can divide as vascular causes, which are most common, then muscular causes, cardiomyopathies, and arrhythmogenic causes. Okay. Then second thing is non-cardiac cause. So on the top two are the pulmonovascular causes. So pulmonary embolism is the number one cause. Second is respiratory arrest. So these are nothing but pulmonary causes, and second you can take as major trauma and hemorrhage. Third, so you can divide it as three, you can take it as major trauma, hemorrhage, and acute intracerebral hemorrhage. So hemorrhage anywhere, either intracranial or outside. So hemorrhage is the second important non-cardiac cause. First is pulmonary cause, third is intoxication. So these are the important causes or etiologies of cardiac arrest. So I need to just rub these things. Okay. Moving forwards, so these are the important causes of cardiac arrest. Coming to the rhythms which we will see in the cardiac arrest patients. Okay, so making tables becomes very easier and very easy to understand things now. So you can divide it as shockable rhythms and non-shockable rhythms. Shockable rhythms include ventricular fibrillation and pulseless ventricular tachycardia, and ventricular fibrillation is the most common rhythm in coronary ischemia related sudden cardiac arrest, meaning ischemia related cardiac arrest. The most common rhythm is ventricular fibrillation, and these shockable rhythms have the best prognosis. Remember this point. Second are pulseless electrical activity. So what is happening? So there is mechanical contraction of heart, but there is organized electrical activity in the heart, but there is no mechanical contraction. There is electrical activity, but there is no mechanical contraction. So that is known as pulseless electrical activity. And second number is asystole. So there is no electrical activity also and mechanical activity. So this has poor prognosis compared to the shockable rhythm. So these are the two types of rhythm which we see in patients with victims of cardiac arrest. So these are the common arrhythmias which we see in patients with the cardiac arrest. So first A is, see, this is V1, I think this is V1 lead, V1 lead. See, this is R pattern. Okay, so that nothing but atypical right bundle branch plaque pattern, and there is broad QRS complex, and the rhythm is regular. So it is ventricular fibrillation, RR pattern. Or you can also remember, if you have seen the videos on arrhythmias. So this is, there are two rabbit ears, no, two rabbit ears. So if the left rabbit ear is longer than the right rabbit ear, then it is ventricular fibrillation, ventricular tachycardia. Sorry. And if the right rabbit ear, right bundle branch block, if the right rabbit ear is longer than the left rabbit ear, that is right bundle branch block pattern, SVT with right bundle, SVT with aberrancy. It is SVT with aberrancy. So you see here, this is the right ear and this is the left ear. So left ear is longer than the right ear. So it is ventricular tachycardia, not SVT with aberrancy. This is torsitis depointis. See different amplitudes of QRS complexes. They are varying amplitude of QRS complexes. This is torsitis depointis. C. And this is ventricular flutter. This is ventricular flutter. If you calculate the heart rate, it is approximately more than 300. Okay. And the QRS complexes are more than 3 small squares. So it is ventricular flutter. Ventricular flutter. Maybe some accessory pathway, I think. If it is there, then this kind of ventricular flutter you can see. And this is ventricular fibrillation, fibrillatory wave. So you can see, so the QRS complexes are wide, and you can see fibrillatory waves. So this is VF. So these are the common VT and VF are the common arrhythmia C. Now, what is the epidemiology? Just remember this one. Sudden cardiac arrest accounts for 15% of all deaths. Oh, 15%, meaning 15 in 100 patients will die due to cardiac arrest. And that too, it will increase up to 50% in patients with cardiac patients, cardiac disease. So cardiac deaths are half of the patient with cardiac disease will die due to cardiac arrest. That means, okay. Overall, out of hospital, OHCA, out of hospital cardiac arrest survival to hospital discharge is 10%, that rate. Okay. In hospital cardiac arrest is often preceded by clinical deterioration up to 80% of cases. In hospital cardiac arrest survival to discharge time, the frequency is 18.5. So that means patient who recovers in hospital and the survival rate till discharge is more more in hospital patients compared to out hospital patients. Okay, that's just to remember. That means we should transfer a patient with cardiac arrest as soon as possible to the cardiac hospital, specialized hospital, so that mortality gets reduced. So now comes the important thing. So how to give, how to provide. So you can divide this support till you call the emergency medical services into basic life support, BLS, and ALS, advanced life support. Basic life support is given by a bystander or some person which is noticing a patient who is not aware, who is not breathing. And advanced life support is provided by a medical person, but by the medical fraternity. Okay, so till the medical fraternity reaches the point, the BLS should be provided by the bystander or something who is available there. So BLS involves interventions that nothing but chest compressions and ventilation aimed at maintaining circulation and oxygenation. High quality compressions and ventilation is important. CPR is what? Cardiopulmonary resuscitation. So what is that high quality CPR? We will know. This is important to know. Why? Because if your quality of CPR is less, no, the circulation to the vital organs, mainly the heart and the brain, is very much compromised. That's why there is a need for high quality CPR to be given to the victim of cardiac arrest. So you can see these are all the things you should do. Compression rate should be 100 to 120 compressions per minute. This is in case of ALS. You should give 100 to 120 compressions per minute. 100 to 120 compressions per minute, meaning in 1 second you should give 2 compressions, at least 2 compressions. Compression depth, till how much the sternum should you should depress the sternum. So approximately 5 to 6 centimeter. Chest recoil, allow full release of pressure between compressions to maximum the venous return. So recoil is also very much important, because venous return will occur only when there is full recoil of the chest. Minimize the interruptions. So less than 10 seconds between 2 compressions, the minimum time should be less than 10 seconds. Okay. So unsecured airway, What should be the ratio? 30. Mic will take its path. So ventilation, each breath should last approximately 1 second. So if when you're giving, each breath should be at least 1 second you should give. Okay. And defibrillation, use AED, meaning automated electrical defibrillator, immediately when available. Defibrillation within 3 to 5 minutes can increase survival rates up to 50 to 70%. See the survival rates. So defibrillation as soon as possible is very much important in these cases. Okay. Delaying defibrillation will decrease the prognostic value for the patient. Okay. So this is the high these are the things which should be one should bear in his or her mind while performing CPR to a victim of cardiac arrest. Now moving on to the, so how you will give CPR. We have called the emergency medical services. Now you want to buy time. So patient will have, you just call the patient if he is not aware, and you just perform, you just see whether the respiration is there or not, patient is happening or not. So Mac Master says to keep the cheek on the mouth of the patient, and if you feel the air there, exhale and inhaling air there, then the respiration is there. If you don't feel for 10 seconds on the cheek, that means the patient is in respiratory arrest also. Okay, so that means the patient is does not have any response and is not breathing. So patient will have obstruction by tongue and glottis. So you should first we need to remove that by two maneuvers. Number one is head tilt and chin lift. So you should tilt the head and lift the chin like this, which is shown in this figure. Or second thing is jaw thrust without head tilt. You just hold the both sides of the jaw by 4 fingers with the tongue on the both sides of the mouth, and you just give a thrust upside. So that is jaw thrust. So this is usually performed in patient who are suspected to have cervical injury, because they are at risk of what we call quadriparesis. So patient who are suspected with cervical injury, don't perform head tilt and chin lift, just perform jaw thrust, that is enough without head tilt. Okay, so this is first one we are going to do. Then second one, if you have automated defibrillator or the patient is in emergency medical services, we need to place the electrodes first. So what will be the position? So there can be 4 positions. The most common is this one. Most common is this first one position. Most common position is this one. Apex and front. This is the apex and this is the first front, or side to side, or apex and back, or front and back. So these are the 4 positions where you can place the electrodes. Okay, see, these are the images. Now how you will perform the CPR? See the posture here. 1 minute. First you see this posture. Place the patient on the ground on a hard surface, and the person who is giving CPR should be bent on the knees, and see the posture of the hands. They should be like this, and they should be placed on the lower half of the sternum, and compressions should come from the weight of the body like this, as shown in the arrow. They should come from the weight of the body like this. Okay, that's how one should give CPR. So this is one more image to show the posture of the hand. They should be like this. Okay, hands should be straight, elbows should be extended, and the weight of the body should act as a force for compressions. So this is one thing which is showing what to do CPR. So what you will do, first you will call the emergency medical services, check the response, whether the patient is aware he is taking breath, nothing. Start compressions, open airway and give 2 breaths, 30:2 in bay. So for every 30 compressions you should give 2 breaths. For every 30 compression you should give 1 breath, means for every 30 compressions you should give 2 breaths. Okay, repeat set of 30 compressions, meaning every 15 compressions you should give 1 breath. Okay, and one thing you should keep in mind is that when you are giving the breath, the chest should rise. That is effective breathing. You should see the rising of the chest. Okay,
And nowadays, because of risk of HIV transmission, hepatitis B transmission, uh, mouth to mouth breathing is not possible. In that case, the guidelines are one can perform only chest compressions, chest only CPR, that is called as chest only, chest compressions only CPR. Or you, if you have some bag and mask, you just keep it on the mouth of the victim, and by that you give the air and you just carry on the compressions on the victim. This is another chart. So you perform the head tilt and chin lift or jaw thrust, then you give the CPR and mouth to mouth breathing. This is there. Okay, so this is not recommended nowadays. You can have some mask, and by that you can give, or you can give only chest compressions. So what is the difference between in infants? How you will give? You will give mouth to mouth breathing in infants. Okay, you will perform head tilt and chin lift, and by 2 fingers you will press the sternum. By 2 fingers you will press the sternum. This is one method. By 2 fingers you will press the sternum. Another method is by you will hold the chest of the infant such that both of the thumbs of both hands, they will be on the lower part of the sternum of the infant, and you will press the infant like a sponge. Okay, like you are holding a sponge and you are pressing that sponge. You press the sternum by your thumbs in that infant. That is the most common method which is performed, and you will give mouth to mouth breathing like this to that infant. That is the difference between adult CPR and infant CPR. And one more here mnemonic you can remember is airway. A for airway, open airway, head tilt and chin lift. B for breathing, check breathing. If not breathing, abnormal breathing, common CPR. C for CPR, 30 to 2 breaths. D for defibrillator. So this is also very important. A common mnemonic: A for airway, B for breathing, C for CPR, D for defibrillator. Okay, A for airway, B for breathing, C for CPR, D for defibrillator. See, this picture shows a demonstrates the CPR in infants. See, now you are the person who is giving CPR. He is holding the chest of the infant like this, and he is pressing by the thumbs in the lower part of the chest, and somebody is giving breathing by mask. Okay, so that's how in infants the CPR is performed. So we have discussed these things. So you need to do CPR until the emergency medical services arrive. Till that time, basic life support should be given to the patient. So we have learned this part of this thing: collapsed, short for help, assess patient. Okay, this part. So when there are no signs of life, you will do ABCD: A for airway, B for breathing, C for CPR, D for defibrillator. These 4 things. But if there are signs of life, patient is aware, or patient has pulse, or patient has breathing, then what you will do? You will assess ABCD: airway, breathing, circulation, disability, nothing but consciousness. E for exposure, temperature, or some bleeding, hemorrhage. Okay, ABCD approach you will follow. Recognize and treat oxygen, and gain IV access, and monitor the patient. Call the resuscitation team if appropriate, then hand over to resuscitation. So you will have IV access, you will give oxygen, and you will monitor the patient. So if the patient has signs of life. So that was about basic life support at the point of cardiac arrest. What one should do, that was about. So when the resuscitation team arises, then you should hand over the patient to the resuscitation team. So advanced life support, that is, they will provide advanced life support. ALS involves team-based procedure using CPR, advanced airway management, and medication administration. So they will also perform CPR, but the quality of CPR will be higher, and airway will be advanced. But 2 things will be added in this advanced level. The one thing is defibrillation, and the second thing is drug administration. So these 2 things will be done by this team. Especially other things will be, the quality of other things will be raised. CPR quality will be raised, so airway will be advanced. All those things will be done. So these 2 things will be done by this CPR, what do you call this team. So this is a flow chart, master flow chart, you can say, of advanced life support. So you found some person unresponsive and not breathing normally. Okay, then you will call the resuscitation team. Then you will provide CPR 30:2 ratio. Okay, attach the defibrillator and monitor the patient. Minimize interruptions in CPR. They will then assess the rhythm. So this will be done by the emergency medical services team. So assess the rhythm, or you can also do, if you have that facility, that patient. Okay, assess the rhythm. So the main thing is whether the rhythm is shockable or non-shockable, because the management depends upon that. If the rhythm is shockable, then defibrillation will work. That will be the mainstay actually. If the rhythm is shockable, for example, shockable with ventricular fibrillation and pulseless ventricular tachycardia. If the rhythm is shockable, how you will assess the rhythm? By attaching the patient to monitor, or by obtaining an ECG, you can assess that rhythm. And if the rhythm is not shockable, then the main things will be to reverse the reversible causes. And you will give CPR and drugs, because the rhythm is non-shockable. You can't give shocks to this patient. And once the patient has ROSC, return of spontaneous circulation, you will give post cardiac arrest treatment for that patient. So you will see here. So assess the rhythm. If the rhythm is shockable, meaning VF or pulseless VT, give one shock. Provide CPR. Minimize interruptions. Immediately after giving shock, immediately resume CPR for 2 minutes without any interruption. Again, after 2 minutes, you will assess the rhythm. Okay. Again, when you assess the rhythm, you will find one among these three, either VF or VT, or return of spontaneous circulation, or non-shockable rhythm you will have. According to that, you will manage. If again the rhythm is shockable, again you will give one more shock. So after second, or according to some book, after third shock, you will give epinephrine 1 mg IV. After the third failed third shock, you will give amiodarone. That is the important point. So after second shock, you will give epinephrine. After the third shock, you will give amiodarone 300 mg IV bolus dissolved in dextrose. Okay. In non-shockable rhythm, there is no role of defibrillation. You will provide CPR every 2 minutes, and you will give drug epinephrine, okay, every 3 to 5 minutes 1 mg, and you will assess the rhythm. Now, if the patient has ROSC, meaning return of spontaneous circulation, then you will have these things. Use ABCD approach. Maintain the airway, breathing, circulation, okay, disability, exposure. Aim for SpO2. Saturation should be maintained 94 to 98%, and aim for normal PSO2, no permissive hypercapnia or something like that, which is used in ARDS. Okay, so saturation should be 94 to 98%. Normal PSO2. Dual lead ECG you should obtain. Why? So there can be some preceding factor like acute coronary event can be there, which can be reversed by PCI or thrombolysis, or some angioplasty, something like that. So we can find that and we can treat that. So we will treat the cause. If it is a structural cause or vascular cause or some electrical cause, we can treat that cause. So treat the precipitating cause, and targeted temperature management is one very important thing. So this is something called as therapeutic hypothermia. In which you will this is given actually in comatose patient. So patient who have ROSC but still they are comatose, meaning the GSCS is less than 8, then you will maintain the therapeutic hypothermia, meaning 32 degrees Celsius to 36 degrees Celsius temperature you will maintain. Hyperthermia is not good for this patient, so you will maintain for 24 hours this temperature. Okay, so that is targeted temperature management to prevent injury, because this maintaining some slightly borderline hypothermia, what it does is it will decrease the metabolic consumption of the brain. Okay, that's how it works. So that's the thing. Meanwhile, you are doing all these things. So while you are doing these things, while you are performing these things, you should, during CPR, what should you do? You should have high quality chest compressions, minimize interruptions, give oxygen. You should perform waveform capnography so that you will get to know whether the patient is getting ROSC or not. Continuous compressions when advanced airway is in place. Vascular access, IV, if not possible intraosseous. Give adrenaline every 3 to 5 minutes, especially in non-shockable rhythm. And in shockable rhythm, epinephrine can be given after failed second shock. Amiodarone after the third failed shock. Okay. Treat the reversible cover. Remember, as 4Hs and 4Ts, famous mnemonic. Hypoxia, hypovolemia, hypo or hyperkalemia, and metabolic acidosis. Hypothermia. So these are 4H. 4Ts are thrombosis of coronary artery or pulmonary artery, pulmonary embolism, tension pneumothorax, tamponade, cardiac tamponade, toxins. So you should reverse these causes. And consider ultrasound imaging, mechanical chest compression to facilitate transfer and treatment. Consider coronary angiography and PCI in patients who have evidence of ST segment elevation or new onset left bundle branch block. You should, even if the patient is unconscious, you should perform this coronary angiography and PCI and angioplasty. Okay, And books also says that if you have a very much high suspicion that the patient had cardiac event, and as we have learned just now that the most common etiological cause of cardiac arrest is nothing but ischemia or acute coronary event, so you should perform angiography and you should do the intervention. Okay, that's that. These things you should consider. Treat the reversible causes. So this some so you have shockable rhythm. The main treatment is defibrillation. So you will start the CPR, you will apply the pads to the patient, confirm the rhythm VF or VT, and resume CPR. Again, you will, while giving CPR, you will charge the defibrillator. You will develop the first shock. Okay, and again you will give CPR for 2 minutes. Okay, notes: pass less than 5 seconds to confirm rhythm. Less than 5 seconds. Okay, minimize interruptions. So how much energy shocks you will give? For biphasic shocks, 120 to 200 joules. The setting should be there. Okay, 120 to 200 joules for biphasic. For monophasic, 360 joules should be there. 360 joules. Okay, do not pause to check rhythm or pulse. Do not pause the CPR to check rhythm or pulse. And along with seeing the rhythm, okay, performing the CPR, giving the shocks, you will also give drugs. Epinephrine 1 mg IV after failed second shock or third shock for some books, and repeat every 3 to 5 minutes. Alternate CPR cycles. Amiodarone 300 mg IV bolus in 5% dextrose after third ineffective shock. Repeat dose of 150 mg may be considered later. Okay, remember this one. That is about shockable rhythms. In non-shockable rhythms, the main goal is to identify and treat the reversible cause. Okay, so epinephrine should be administered 1 mg IV immediately upon gaining vascular access, and then every 3 to 5 minutes. Treat the reversible cause like 4H and 4Ts. Must be actively sought and treated during the CPR. This should be treated during the CPR. Okay. Now, this is an important table. The 4H and 4Ts. How you will reverse. So if it is if it is hypoxia, so secure airway, give oxygen. Hypovolemia, IV fluids and blood, and treat the underlying source. Hyperkalemia, metabolic acidosis, treat the specific abnormality. Okay, sodium bicarbonate for acidosis and hyperkalemia, calcium chloride for hyperkalemia or calcium blocker overdose. Okay, so 2 drugs, sodium bicarbonate and calcium chloride. Okay, hypothermia, rewarming. Yeah, so in comatose patient, target temperature is 32 to 36 degrees centigrade. So tamponade, you will perform pericardiocentesis, pneumothorax, needle compression, and then thoracostomy or ICD insertion. Thrombosis, coronary, acute coronary event or MI, you will perform PCI or revascularization therapy. Thrombosis of pulmonary, this is one only, this is 1T. Okay, pulmonary embolism, thrombolysis or embolectomy. Toxins overdose, antidotes administration, for example naloxone for opioids and lipid emulsification for lipophilic drugs. Additional T trauma, rapid body surgery, treat hemorrhage and hypovolemia and hypoglycemia. This is one important thing in children. Hypoglycemia, additional H in there is one additional T for trauma, there is one additional H for hypoglycemia in children. Treat with glucose, not explicitly listed above but commonly included in pediatric protocols. Okay, so that's how we will so just remember this 4H and 4Ts. Then when hypoxia, hypovolemia, hypothermia, and hypoxia, hypovolemia, hypothermia, and hyperkalemia, metabolic acidosis. T's, thrombosis, tension pneumothorax, tamponade, toxins. Okay, so we need to reverse these things. So this is how you should give the shock. This is the things. So these are the 3 common ways which to give a shock to the patient. The usual standard way is this one. So apex to front, pads on the front and side. Second common way is apex to back, which we have learned. Okay, both one after other, you are utilizing both the things. So one time you are giving this like this, and another time you are giving apex and back. So combine both of the above. See, here there are pads. You will pay the pad, and you should be the provider, the personal, the executive personnel should be away from the bed, and he should deliver a shock. If it is biphasic, 120 to 200 joules, and if it is monophasic, 350 joules of shock, 300 to 350 joules of shock you should deliver. This is the standard way, apex and front, and you can alternate the way of shocks also. Okay, that's about the thing. Now other things, advanced airway, these are all ALS, no? Advanced airway and ventilation, how you will give advanced airway to the patient. Airway security, tracheal intubation is the most reliable but should be done by skilled providers within less than 10 seconds. Less than 10 second interruption time. So there should not be any interruption to compressions. Okay, tracheal intubation, but this can be performed only by skilled professionals. For those who are not skilled, so for them the thing is supraglottic airways. In these there are two, laryngeal mask airway and one more is eye gel. The difference between these two is this is made of plastic and this eye gel is a specialized type of laryngeal mask airway where the part which fits upon the mouth of the larynx is made up of a gel. Okay, so it will mold to the shape of the larynx. So it is easy. Eye gels are very easy. Okay, these are safer for less experienced providers. Then post intubation ventilation. Now you intubated or you have given the LMA. Okay, chest compression should be converted 100 to 120 per minutes and ventilate asynchronously. Approximately 10 breaths should be given by ventilation per minute. In 60 seconds 10 breaths should be given. That means in 10 seconds you should give approximately 1.5 to 2 breaths. Okay, then capnography should be performed, so whether to know the patient is having ROSC or not. Okay, so what is the sign of ROSC? There will be rapid endotracheal tube carbon dioxide rise, and that should be more than 40 mm of Hg. Okay, if it is there, then that confirms ROSC. And this is also useful in confirming tracheal tube placement and monitoring the CPR quality. So the figures here are not the figures of ventricular intubation, because all of us know that thing, and that cannot be found by everybody. This is a figure of laryngeal mask airway. So someone is this is nothing but the laryngeal mask airway. Like this he will insert, okay, and he will inflate by here. By this he will inflate, and this is also LMA, but a special type of MA known as eye gels. So here what you will do, this is made up of gel like thing. It gets molded to the shape of the larynx. There are 3 different sizes, 3, 4, 5 of eye gels. So for 30 to 50 kgs you will give the size of 3, for 50 to 90 kgs you will give the size of 4, and for more than 90 kgs adults you will give the size of 5. Okay, just remember that thing. Insertion technique of this, because this is very easy to insert, just remember, see here. So this is inflatable part of that laryngeal mask airway which fits upon the larynx. You just deflate by taking a syringe. You deflate and you compress with the other hand that mask, okay, by the index finger and thumb. Deflate and you take by syringe till you get vacuum. You feel vacuum here. Then after deflating, on the back side of that laryngeal part of that LMA, you lubricate with jelly. Then you will insert like this. You will proceed. You will point that this part you will point towards the hard palate, and this part will point towards the chest of the patient, and you will just give like this. You will go like this till you feel a resistance. Okay, see here, he is going along the path of the hard palate and soft palate. So after going like this, you will feel a resistance, a absolute resistance at this point. So at this point what will happen, that part of laryngeal mask airway will get lodged onto the larynx above the vocal cords. So these are supraglottic airways. So when you get when you have done that, just tape it by this, and after taping only you just inflate the balloon so that it gets fixed at this site, and then you will give ventilation by through this route. Okay, that's about the LMA insertion technique. To know in detail, you can watch in detail some video of that. Okay,